disgusting, gross, all the above. Anybody at all? Something you'd like to share with the class? Because I would sure like to hear about it. My. That's disappointing.
Okay. Well,
okay, thank you, Naomi.
Okay, yesterday. And that was pretty cool. I got the experience to get a little more practice in, got my chest competency.
Oh, nice.
But it was definitely interesting because there was a spine x-ray, and this lady was actually paralyzed on her left side, and she was in so much pain when we were trying to position her. But she was like in good humor about it. She had her daughter there. She kept apologizing. She was cussing a lot. She's like, I'm so sorry. And we're all kind of laughing at her, but she doesn't stop cussing the entire time. So lots of pain. I felt really bad for her. But got the image.
So you use your superior patient communication skills to diffuse the cursing session.
The tech was really nice. She was like, I understand. You're in pain. It's all good. But yeah, that happens. But chest competency, finally.
Yay, very nice, very nice.
Yep.
Very nice.
Hopefully moving on to something else, like KUB, maybe upper extremities tomorrow. We'll see.
And then comes the image review. I have to say that with that evil laughter, you know. No, not really. It's not that bad. It's not that bad. Very good. Glad you got the chest comp. And glad that poor lady that was cursing got her spine exam done. Someone else was speaking up. Was that you, Jonathan? You were about to say something? Someone was about to say something at the same time Naomi was speaking. It sounded like a male voice. Anybody? So Naomi's the only one with a cool story yesterday? I mean, you can tell us about, did anybody else get a comp yesterday? Okay, Jessley, what did you get?
The hand.
The hand, very nice. And John, I believe you got the same, correct? You got a hand as well? Very nice, very nice. So some of you do have more than one now, and that's really awesome. I'll always encourage you guys to get as many as possible to carry over the next semester. You do only need one, but this is a requirement on your clinic grade. But those of you who are not. Go ahead, Jonathan. Were you trying to say something? I think we're losing your feed there. I'll give you a chance to talk though once you get reconnected. But yeah, guys, those of you that have not got your competency yet, do keep in mind it is October 14th today, and we are pretty much at the midpoint of the semester, even though it feels like we just started. And in many ways, we did just start. It flies by very fast. Because think of it this way. We're about to get through October. We get through November. And pretty much at the end of November, that pretty much wraps up the semester because the first week in December is pretty much makeup week, and then finals are after that. So we don't have a lot of time left. It's already about to wrap up that fast, and you're going to be past your second semester already. Not trying to scare you, but pace yourself. Get in there and get that comp as soon as possible because you do have to have at least one by the end of the semester. Jonathan, were you about to say something? I know you were having some connection issues there.
Yeah, I was just gonna just talk about. I was in the floor yesterday, and that was pretty cool. The patient that we had, he had fractures on both of his legs, and so the first one, it was pretty crazy. Like there was like 3 surgeons trying to fix it or trying to get it to work, and they were having some kind of issue. But the one thing that really stood out to me that we talked about in class was C-arm. They didn't have it. They didn't have it wrapped up properly. And that thing is covered with blood. Like 2/3 of it was just completely drenched in blood. And I was just thinking, like, okay, I now understand why he's talking about when he says, make sure you drape the arm. Because that did not look like blood.
See, you thought I was lying, didn't you? I tell no lies. I'm telling the truth.
It was crazy. But, like, yeah, the surgery was pretty cool. Like, on one of the legs, like, they literally just, like, had the entire thigh. And cool looking. And there was one surgeon that just like basically control of the C-arm. He was cool and everything, but he was just like, let me do this, let me chill. He sat there for like 15 minutes taking control of everything. And And so the tech was just kind of like, okay, whatever. But it was a pretty cool experience overall.
So, Jonathan, did you have to go in there and scrub the machine, help scrub the machine down when it was over with, or?
No, I was thinking about that. The rotation ended and the surgery was still going on.
Oh,
so I was just
worked out.
I was like, okay, it's time for me to go. So yeah, I was worried about actually do that, but I lucked out.
You're like, have fun with all that cleanup. I'll see you later. Goodbye.
Yeah, right.
Case point, guys, just like we talked about in class, that's why it's so important to make sure that machine is wrapped up properly, because just like Jonathan described, if you didn't hear him, those surgery cases, when you don't wrap that C-arm up, it's going to be covered with blood. And when you're a technologist, you're going to be stuck cleaning that C-arm for a long time afterwards, because blood does dry up very quickly, and it stains, and it's very hard to wipe up once it dries. So wrap that C-arm properly. It's going to save yourself a lot of headache. All right. Do we have just one more person that wants to share something before we get moving here? I know y'all got to have more than just that. There's always some kind of action going on at the hospital.
I saw kidney stones, and I did not envision them how I thought they would look.
Oh, explain that. And what do you mean exactly?
Well, to me, the kidney stone itself looked like a Frosted Flakes cereal with like a Dorito. That's how it looked.
So you actually got to see the stone, like outside the body. What you talking about?
No, like I could see through the camera.
Oh, okay, yeah.
They were lasering it off.
So you were on a lithotripsy in the OR. Is that what you were?
It was urology.
With urology, yeah. Were they using the lasers, you said?
Yeah.
Yeah, it's a lithotripsy.
Oh. Yeah, I didn't sort of kidney stone.
Did they make you wear the goggles? I recommend wearing goggles when you're in. Have those provided for you. That was my very first exam when I was a student. My first rotation was in surgery, and the very first thing I saw as a student was a lithotripsy, using that laser to break up those kidney stones. And we had to put these big goggles on. We looked like stormtroopers from Star Wars. It was crazy looking. Very cool surgery to see if you have not seen that before. I just got through teaching the seniors on kidney stones yesterday, as a matter of fact. We were going over urinary anatomy yesterday. But yeah, it was kidney stones. I don't know if anybody here has ever experienced a kidney stone. They say that's a pain worse than childbirth, from what I hear. I can't confirm or deny that because I have never had a child. But from what I'm told, those kidney stones are the worst possible pain on earth, because if you've never seen a kidney stone, they're actually kind of spiky looking. And when you're passing that kidney stone from your kidneys to the ureters to the bladder, it's raking your ureters and scratching them as it goes down and passes through your body. Then it sits into your bladder for a little while, festers for a while, and if they didn't remove it surgically or break it apart with those lasers, you got to pass it through your urethra. You have to pee it out. And that same spiky substance is raking the inside of your urethra as you're trying to pass that urine and that stone out. And that's where they say that is the worst pain on the face of the earth. Like on a scale of 1 to 10, it's a 1,000. That's what I've been told, at least. I've never had a kidney stone. I guess I need to stop drinking so many sodas. I hear a lot of Coca-Cola and sodas can cause that. I sure do love my Coca-Cola soda. I don't know if I can give that up. Thankfully, from what I hear, coffee does not cause kidney stones. If they ever discover it does, I think I'll go cry in the corner. But hopefully never have a kidney stone, because I hear it's quite horrific. Cool that you got to see that. Cool that you guys got to observe some of the things we were talking about in class. You're going to see more and more of that as we share things in class. You're going to start seeing it firsthand. Definitely come back to the class and share that. Nope, I'm saving that one for later. I had a story, but I'm going to save that for another lecture. Keep you in suspense on that. Okay, so before we move on, I suppose you guys would like to know who won the modeling contest. Well, I'm going to tell you at the end of class because I'm still going over it in my head. I'm sorry. Yeah, I got about 4 of you that I'm passing through my head right now. I got it narrowed down to 4, and I'll make my decision at the end of class and share that with you. Who will get the bonus points? It's a very hard decision. Better on this one than the last project. What's that, son? Were you going to say something?
Oh, why you don't give honor for people get the score?
Because it's a competition. Can only be only one winner. All right, guys. Hey, and besides, you all get a bonus point from me every test. What you talking about? You always get that free question at the end. Everyone here gets a bonus point on every test. See, I keep it fair. All right, let's pull up the PowerPoint, guys. We're going to keep moving along here through our shoulder girdle chapter. Okay, so last time, guys, we left off talking about the humerus. We had just went over the AP and lateral views, and we left off here on our transthoracic lateral humerus. Now, the full name for that exam is going to be referred to as the horizontal beam transthoracic lateral humerus. That's the full name for that exam. But most of the time, you'll see it simplified just down to transthoracic lateral humerus. Now, as you see in parentheses there, this is going to be the exam that we do on the humerus primarily for trauma cases. Now, what do we mean by trauma? Not necessarily people just coming to the trauma room, but this is going to be reserved for those patients who have a fractured humerus and cannot move that humerus into a traditional lateral view. Now, this is only for lateral views. We're still going to acquire that AP in the normal fashion, but when it comes to doing a trauma, person that cannot move that arm and put it into a true lateral, we're going to opt for this transthoracic lateral humerus exam. And as you guys have done in lab, this is an exam where we actually shoot the humerus through the torso of the body. And that's the reason that this is reserved for those trauma cases, because those patients that cannot move that arm due to it being fractured, this is another way to get a true lateral humerus x-ray to hopefully evaluate how bad that fracture is. Now, as you can imagine, and I'll show you some pictures of it, it's not going to be what we call a top quality x-ray because we are shooting through the chest. The chest is quite thick in the lateral view. So it's not going to give us a beautiful x-ray of that humerus, but it's still going to provide us with just enough information that we can make a proper diagnosis to see how severe that fracture is and help them get the help they need to fix that injury. Now, as far as positioning goes on this position here, this can be done either standing up or lying down, erect or recumbent. And it's going to be a lateral of the affected side. What that means is whatever side the patient has pain in or where the fracture is, we want to make sure that arm is what's touching our IR. On the other, we're going to lift the opposite arm up above the head. We need that arm up out of the way so it does not superimpose the affected arm. And as you can see this lady demonstrating in the picture here, we have that unaffected arm all the way up on top of the head, getting it out of sight, out of mind. That way we can focus primarily on that humerus through the chest cavity or torso. Now our SID will be 40 inches, just like everything we've been talking about all along here in this chapter. It is going to be a perpendicular CR, and that's going to go through the mid aspect of the involved humerus. Now you might be looking at that picture and say, well, how in the world do I put my CR on the midpoint of the humerus if I can't really see it? Well, what I do personally is I will actually turn my patient so that they're in the opposite lateral, and I'll put my CR on that affected humerus first to find the midpoints. Then once I know I'm centered, I'll go ahead and turn them so that the affected arm is going ahead and touching the IR. I move the unaffected arm out of the way, shooting through the torso. And since I already found that centering, turning them the other way, first of all, my centering is going to stay the same. And I don't have to sit there and try to guesstimate it. That's my personal strategy. You may not see it that way, but that ensures to me that I have that centered correctly to that mid humerus. Because if you try to just guesstimate it, shooting through the torso, it's very easy to cut off either that proximal or distal end of that humerus. Now, as far as this x-ray is concerned, this is going to be one of the few x-rays in the shoulder girdle chapter where we actually going to do controlled breathing. As a matter of fact, it's going to be similar to a breathing technique where we have the patient just breathe normally. And the reason for that is because we are shooting through the torso of the body. To better visualize that humerus through the torso, we need to blur out the ribs. So we're going to tell our patient before we make our exposure, just breathe normally, take controlled shallow breaths. And that motion of breathing is going to blur the ribs out. And hopefully, if we set the ideal technique, help that humerus show up all the better through the torso cavity. That will be on a 14 by 17 cassette lengthwise, much like the other humerus x-rays we've already done. And that's going to demonstrate our entire humerus in true lateral without rotation. This can be done at the wall bucky, the table bucky, or tabletop with the grid, and definitely with the grid because, if you've learned about grids, we use grids when we're x-raying very thick portions of the body. And because we are shooting through the torso, we'd always want to put a grid on a free cassette to help absorb all that excess radiation, because we are going to use a much higher technique to penetrate the torso and hopefully light up that humerus in a nice quality fashion on that x-ray. Then, of course, gonadal shielding, that goes without saying on everything we talked about. You want that gonadal shielding to be on the side of the body, by the way. Don't leave it on the front of the body. Turn that shielding to the side of the body. That way it's going to protect that patient properly in their gonadal area. So as far as how that x-ray looks like, there's an example right there. This one was done cross table with a person laying down. And as you can see, it's not the most beautiful x-ray. But on the other hand, because of the severity of that break on that humerus, it's broken near the proximal end of the humerus, close to the surgical neck, they obviously couldn't move that arm into a true lateral. So we shot that lateral through the torso cavity. And we can make out quite a bit of that fracture, even though it is quite blurred because we're shooting through that thick torso cavity, but it still gives us a proper diagnosis in these trauma situations when that patient can't move that arm properly into a traditional lateral humerus x-ray. So as far as evaluation criteria, there's only one major evaluation criteria for this exam, because we do have a little wiggle room because it is not ideal. We do want that entire humerus demonstrated within the thoracic cavity. And that's where it's going to be really important that even though we're shooting through the torso, we make sure we find that mid portion of the humerus first, then turn our patient and shoot through the chest cavity to make sure we're centered correctly, and then we have our proximal joints and our distal joint of the shoulder and the elbow, showing that entire humerus in a nice true lateral position. Once again, this is reserved for our trauma patients, trauma cases where the patient cannot move that arm into a traditional lateral position that we would do for normal humerus x-rays. And me personally, as far as the ideal way to do this, if they can stand up for you like this patient right here, compared to laying on the table, you're going to get a much prettier x-ray having them stand up using the wall button in comparison to doing that free cassette. It's going to give you a lot better quality x-ray. Oh, by the way, guys, you guys should have received a chart from me in your email. That's a great thing to fill in as we go along, because it should have all those categories listed for you. Makes a great study guide for the upcoming test. Okay, so we also have another view that we can do for an arm that's really in bad shape and they can't get that true lateral traditional position. That position is going to be what we call a lateral, mid, and distal humerus. And it's done exactly like we see right here. We put the cassette on the inside portion of the arm, have the patient put the arm in a 90-degree angle, and we shoot cross table close to the elbow. And that's going to allow us to acquire that distal portion of the humerus in a true lateral. If the doctor is asking for more views to better visualize it, for example, if we did that transthoracic lateral through the chest and it didn't show the distal portion very good, we can also do this x-ray we see right here to better visualize that elbow joints and further evaluate whatever fracture is going on in that humeral area. So it's just an additional view should that doctor request extra views be done, and that's focusing on that distal, mid and distal humeral area close to the elbow joint. That is done cross table once again with the patient lying down. This would be a recumbent AP position, shooting cross table with that cassette on its side like you see right there, with the arm in a 90-degree angle. Now, as far as the specific evaluation criteria for this exam right here, we are only focused on the mid and distal humerus, so we don't need the proximal portion. The entire 2/3 of that distal humerus should be demonstrated. The arm should be in a true 90-degree angle. And the epicondyle should be superimposed, much like a lateral forearm, a lateral elbow, and a lateral humerus. And of course, the correct exposure factors. And once again, this will be a cross-table exam. Therefore, if you do this x-ray, this technologist did not do that. You want to put X-table, cross-table marker, annotation right under your marker, just indicating to the doctor this was acquired using a cross-table horizontal beam to that cassette. So it almost looks very similar to just a lateral elbow. That is what we call a distal lateral humerus for the mid and distal areas. We are including a little more of the humerus than we normally would for a traditional lateral elbow. All right, so that wraps up the humerus. We're now going to go ahead and move on to the shoulder, primarily the non-traumatic positions of the shoulder. And we do have our routine projections that include the internal and external rotations, as well as our special projections, which are going to focus on what we call the Lawrence method and the Grashy method, both done for very specific reasons. So as far as the technical features go on shoulder girdle x-ray specifically, our KV range is going to range on an analog machine from 70 to 75. On digital machines, we're going to opt for the 75 to 85 kilovoltage settings. Our grids should be approximately greater than 10 centimeters, and we are going to use a high MA. Now, usually we don't like to say high MA, especially on extremity work, but for the shoulder area in particular, we are penetrating a quite thick area. Why? Because your shoulder is very close to your chest. That's where the body becomes a lot thicker. So we are going to opt for a higher MA than we normally would for normal extremity work to make sure that we're visualizing, penetrating properly to get that nice x-ray of the shoulder. Now, despite the high MA, we are going to use a smaller focal spot because we are going to be zeroing in on very specific parts of anatomy depending on what view we do. And if we use the AEC, which Mr. Donahue really hates and does not advise you to do, we will use what's called the center chamber on that control panel. We'll go over more about what that means in PRE. And we will be using a 40-inch SID on everything we're doing except for AC joints. And we'll get more into those here in a little bit. That'll be the one exam that we talked about this chapter where we will do 72-inch SID. It's AC joints. AC joints. Everything else is going to be at 40. I'm sorry I'm drinking so much water, guys. My mouth has been so dry this week. These allergies are wrecking me. Okay, a few more considerations as far as protection is concerned. Of course, we are going to always shield our radiosensitive organs, primarily the gonadal area, but some of your patients may request to have something like a thyroid shield. Typically, we're going to say for your patients, unless they just completely demand it, to not use a thyroid shield. And the reason for that is that thyroid shield does have a danger of actually obscuring portions of the clavicle, primarily the SC joint area, close to the sternum. And we do want to be able to evaluate that if we're doing clavicle x-rays, shoulder x-rays, we'll see that joint space nicely on our x-rays. So go ahead and, unless they completely demand it, don't give them thyroid shields. Tell them it's going to actually obscure anatomy. But as always, go ahead and shield the gonadal area. And no matter which type of shoulder x-ray we're doing, we are going to utilize very close collimation because we are using higher techniques. That's going to help protect our patients from excess scatter, as well as enhance our image quality overall to the fine bony details that we do need to see on the shoulder and the surrounding joints. So let's start with our external rotation shoulder. Now you do see there in parentheses, it can also be called the AP proximal humerus, but more commonly it will always be referred to as an external rotation shoulder. Patient will stand erect. They can be supine as well, but they are preferred to be in the erect position for this x-ray. We do extend the humerus straight out as if we're doing an AP forearm. We supinate the hands straight out in front of us, and we want to palpate those epicondyles on that elbow to ensure they are parallel to our IR to make sure we are achieving that true external rotation for that x-ray. 40-inch SID, and we are going to have a perpendicular central ray. Now, the CR does enter 1 inch inferior to the coracoid process, which is why I told you guys at the beginning, if you could touch on your shoulder, you can feel that protrusion right here. It's quite a prominent protrusion. That's that coracoid process, the one I always love to label. It sticks out quite a bit. If you put 2 fingers down and go inferior, that's where your centering would be for a shoulder x-ray, whether it's the internal or external rotation. Very easy landmark to find. Poke on your patient. Always tell them before you do that, put 2 fingers down, move inferior 1 inch, and you'll have spot on centering for that x-ray every single time. As far as the breathing instructions go, we will tell our patients to suspend their respiration completely. That's to make sure that they don't have a whole lot of excess air in those lungs that could obscure some of the anatomy we want to see, because our prime focus is on the shoulder bones, and the joints. And We are shrinking our cassette size down quite a bit from that humerus x-ray we just talked about. We're going to a 10 by 12 cassette, and that's going to be crosswise, guys. It'll be wide, portrait view, crosswise, because the shoulder area can be quite wide on some patients, and typically we want to include as much of the clavicle as possible on that shoulder x-ray. Even though our prime focus is the humerus in the shoulder area, we still want to include a lot of that clavicle on there as well, because a lot of people that come in for their shoulder x-rays, they say their shoulder's hurting, but they actually have a fractured clavicle. So we want to go ahead and include that on the x-ray as well. Wall bucky or table bucky, we can use either one. We typically don't want to do this free cassette, but we can if we absolutely have to, because it is preferred to have some sort of grid to help clean up that image, because we are penetrating a thicker area and we need to clean up that excess radiation to give us a much better picture. And then, of course, gonadal shielding. We're repeating that over and over again, but we need that gonadal shielding on the AP surface of our patients to protect them in that area. As far as that marker placement goes, guys, most of your shoulder x-rays, you should have a little bit of light above the shoulder. That's always the perfect location to put your marker. And you can always turn your marker if you need to. Try not to do what this tech did and put it in the actual shadow. Always say if your marker is in the shadow, it's going to be in the anatomy on the x-ray. The shadow is going to indicate where the anatomy shows up on your x-ray. So always put that marker in the light area only. Otherwise, you might end up having it in the actual bones, shoulder joints, humerus, whatever. Now, as far as the evaluation criteria, it should look very similar to this x-ray we see right here. We do want to see that greater tubercle profiled laterally. So we talked about in the anatomy section. If you remember, our greater tubercle or tuberosity is right here, very prominent. It's in true profile. That indicates to me and indicates to the radiologist that we did extend that arm and rotate it externally for that external rotation. And we do want to see the scapulohumeral joint centered. That's why we do center an inch below the coracoid, because that's very close to our scapulohumeral joint or glenoid fossa. That's where we essentially want the anatomy to be centered upon the film. And we do want to make sure we include the proximal humerus, the upper scapula, and the clavicle mostly, but not required to be all the way visualized. Now, me personally, I always include the clavicle all the way to the SC joint, even though that's not required in your criteria. I go ahead and include it on my x-rays because, like I said, based on my experience, a lot of patients come in with shoulder pain and they don't realize it's actually their collarbone or their clavicle that's fractured. And if you cut that off, you might be obscuring where that actual fracture is, and they'll send them home and never actually have that fixed properly. So me personally, I'll go ahead and open up my collimation field just a little bit to make sure I include at least the SC joints. That's Mr. Donahue's method. That's not what your book requires. You just need most of the clavicle included on that x-ray, but not all of it. Of course, the main thing we always look for, and make sure you can tell a difference between this, guys, when you're looking at these images. Make sure if I throw an image that looks like this on your test, that you can tell me that is an external rotation. And how do we know that? This very prominent greater tuberosity in profile on the side right here. So before I get to it, what's going to be in profile on the internal rotation? You guys remember what we talked about? What anatomy is in profile on our internal rotation?
The lesser tubercle.
The lesser
tuberosity, or the lesser tubercle. So zero in on that. You're going to see that over and over again. Make sure you can tell the difference between those two x-rays. By the way, what's that little line there represent? What am I looking at? It's very groovy.
Intertubular groove?
Intertubular groove, yes. That's the groovy piece of anatomy, guys. Come on. It's very groovy. Very, very groovy. You're throwing some of that 90s slang at you. Come on. Ooh, tough crowd today. I got a couple smirks there. Okay. I'll take that. Thank you, Daniel. All right, so let's talk about the opposite one, guys. It's going to be our internal rotation shoulder. That can also be referred to as the lateral proximal humerus. Both are synonymous terms, but much like the external rotation, you will mostly see it referred to as the external rotation shoulder. Positioning, guys, is literally going to be almost exactly the same. The only thing we're doing differently is we are pronating the hand or turning it internally. When we turn that hand internally or pronate it, that's when we put the lesser tubercle or lesser tuberosity in profile. So we do want that humerus extended. The epicondyles will be perpendicular versus parallel to the IR. So on our external rotation shoulder, the epicondyles are parallel to the IR. Internal rotation, the epicondyles are perpendicular to the IR. Very important point to put a star on because people mix those two up quite often. Like I said, the hand will be pronated. That pronation of the hand will put that lesser tubercle in profile for us. Still at our 40-inch SID, we still have a perpendicular central ray, and our centering is exactly the same. We're going to put that CR 1 inch below that coracoid process. And what's nice about this X-ray is usually people will center for the external rotation first, then do the internal second. What's great is you don't have to touch your patient or move them. Your centering should be the exact same spot. You literally just have to tell them when they turn their hand inward, and then you just shoot your X-ray. Very easy to position for. So when you position for that first X-ray, all you do is adjust where the hand is rotated, and you're set up for your second X-ray. Very easy competency to get. Very, very easy to view X-ray. Same as that first one, guys. We're going to suspend that respiration. We're still going to be on that 10 by 12 cassette crosswise, using wall or table bucky, and of course, gonadal shielding. And do make note, guys, from here on, you will start seeing me list a lot of these cassette sizes. We do to make sure we know what these cassette sizes should be on average, so don't overlook those. I know we haven't talked about those much in the past, but moving here forward, that's going to become more and more important when we talk about the different criteria we're going over. So make sure you know what those cassette size are, as well as what orientation they should be set in. So it would be 10 by 12 crosswise or portrait view. Crosswise or portrait view. I'm sorry, landscape view. Landscape view. I apologize. That's landscape or crosswise. I usually use the word crosswise instead of landscape. Go ahead, Maricela. I'm sorry.
For the external rotation shoulder, I know you said that we, we supinate the hand, but in clinic, I noticed that they have the patient bring their arm across their chest.
For laterals, they do, yes. For laterals. Like you're talking about a Y shot? Like a Y shot X-ray?
No, it was an external rotation shoulder. And I asked her because I remember Mr. Fung showed us to supinate the hand.
Your tech, all right, I'm not trying to be rude here, but that tech doesn't know what they're doing. That's incorrect positioning. What she is doing, or she or he, I don't know who it is, arm across the shoulder, like you're telling me, that's a position for when we do lateral shoulder X-rays, which you'll see here in a little bit.
Okay.
That's it. Yeah, do not do that. That's incorrect position error. Very, very bad. That poor tech does not know what they're doing.
Okay, yeah, because she did that, and then she did the internal rotation. She pronated the hand, and then she went to do the Y view.
So they did this for the external?
Like not that high up, but they did do that.
No, that's not. No. I'm trying to be nice. I'm trying not to be too rude. That's completely 100% wrong. We not do it that way. That's not going to give you an external rotation at all. In fact, it's going to give you closer to the opposite of an external. I'm sorry you had to see that, but don't do that.
No, it's okay. I just wanted to ask.
No, I'm glad you did, because I don't want you guys getting mixed up, because some techs get out there and just make stuff up. There's some bad techs out there. I'm sorry to say. Okay, so for our evaluation criteria, guys, it's going to be very, very similar to the external rotation. The only really big difference, of course, is what's going to be in profile. That's going to be our lesser tubercle. And do remember that lesser tubercle will be in profile on the medial side, right over here, close to the joints. There's our lesser tubercle in profile, true lateral profile. We still want that scapulohumeral joint to be the center point of our X-ray. We achieve that by going 1 inch below that coracoid. And we are going to include our proximal humerus, upper scapula, and most of our clavicle, much like the first X-ray, and of course, use our optimal exposure factors. So very similar criteria. The main difference there, of course, is what's in profile. And that internal rotation will specifically put that lesser tuberosity or tubercle in true profile. And make sure you watch your patients on these X-rays, because sometimes they won't keep their hand in position for you. You'll turn around and go check the X-ray, and they relax their hand. Make sure when you're doing the internal, they're keeping that hand internally rotated. Make sure when you're doing the external, they're keeping that hand externally rotated, because they will get slick and tricky on you and try to move that hand when you're not looking. or they don't even realize it sometimes. They relax their arm because it's hurting. That will mess up your whole x-ray, because we do need to see those two distinct pieces of anatomy in profile for each of those views to be acceptable. Okay, so this is one of our specialized view here, guys. This is what we call a Grashy view. And the long name for that view is going to be what we call the posterior oblique to visualize the glenoid cavity or glenoid fossa. And why do we do this x-ray? Well, it's within the name right there. We do this x-ray primarily to allow us to see the glenoid cavity a lot more clearer. It's going to open up that joint space a little bit more so we can get a nice clear view of the inside of that joint space where that glenoid fossa or glenoid cavity is located. Now, as far as the positioning goes, in this x-ray in particular, we're only going to do this erect, standing up. And we're going to actually oblique our patient 35 to 45 degrees towards that affected side, affected arm, affected shoulder, and slightly abduct the humerus. Now, when you see the ranges there, as I told you guys in the past, pick one number. I always pick 45. Why? Because 45 degrees is the easiest to remember, because we do most of our obliques at 45. So if you put your patient in a 45-degree oblique, you're going to get what you need for that view. It's still a 40-inch SID. Now, for the CR, it is going to change a little bit from our other shoulder x-rays. We're still doing a perpendicular beam with no angle, but we're going to have that CR enter 2 inches inferior and medial from the superolateral border of the humerus. Now, that sounds really complicated, but that superolateral border is very close to my favorite piece of anatomy, the coracoid process. So, in my opinion, even though your book puts it this way, a little bit easier way to position for that, because we can't really palpate that superior border very well. That would be a guesstimation. Go ahead and find your coracoid. We already know where that is. That's very much in line with that superior border of the humerus. And go ahead and go down 2 inches. And you're still going to be centered correctly for that x-ray. So that's basically double the inferiority of our shoulder x-ray. So we're going to go just a little bit lower than we normally would for a shoulder. But what really is going to make the difference on this x-ray is making sure that patient is obliqued at 45 degrees. Obliquing them at 45 degrees is what's going to be the main component to opening up that joint space and showing off that glenoid fossa or cavity a lot clearer. As far as our cassette, we're still doing it the exact same way, guys. We're still using that 10 by 12 cassette. We're putting that at a crosswise orientation. We are primarily using wall bucky because we do require patients to stand for this x-ray. And of course, we're going to use our gonadal shielding. So do make sure you do memorize the way your book has this labeled as far as where the CR enters, using that superior lateral border of humerus. But if you're ever doing this in clinic or in lab, if you really can't figure out where that border is, go ahead and find your coracoid, go 2 inches below the coracoid, you'll be in the right spot. It is very, very close to that exact location.
Hey, Mr. Donahue?
Yeah.
For lab, Mr. Fung was telling us the same thing, except he was saying 2 inches inferior and medial from the lateral border of the shoulder. So is that basically the same thing? When I think of humerus, I just like that. I'm sorry. I was just saying that when he said the shoulder, that I just imagined like a little bit higher. Mm-hmm. Would be the starting point of the humerus.
That is what he's referring to. That superior. That's what the superior lateral border is talking about. It's actually right where the shoulder curves.
Okay.
At an angle, like the point of your shoulder. And like I said, that can be a little hard to palpate on patients. That's why I said if you go ahead and follow that around, it does line up quite well with your coracoid. And if you find your coracoid and go 2 inches below, it's going to be in basically the exact same location had you use the superior lateral border of the humerus. They line up quite well with each other. It's a little more reliable, in my opinion, to go ahead and use coracoid. But when we're talking about the superior lateral border, it's about the point of the shoulder right there. The actual point where the shoulder comes up. Yeah. So he was correct. It is the shoulder. It is the shoulder, yes. Or if you guys couldn't see what I was doing on the screen, if you look at my laser pointer, guys, where the shoulder curves right here, comes to a point, that's what that's referring to. Follow that around. Coracoid's right here. You go 2 inches below either one, you're still going to be in the correct spot. So coracoid, just in my opinion, is a little more reliable because we can palpate that a lot easier. Plus, if you use the coracoid, you're going to be medial as well, 2 inches where you need to be anyway. You're going to be centered just right. It's like one of those little cheat codes as I talked about last semester. It's going to be a Grashy method cheat code for you. I don't know why, but this picture always made me laugh. This lady's face looks like she saw something very disturbing in her line of sight. She looks very, I don't know, upset about something. I'm just reading too much into that. I just thought she looks upset in that picture for some reason. And she's like, I wish I could quit having these people position me to these x-rays. I'm tired. I need a break. I'm not getting paid enough for this. Can we move this along? I've had enough. All right, and that's what our x-ray should look like right there, guys. Once again, the main reason we are performing this x-ray is to see that glenoid cavity opened and in profile. And we do want the scapulohumeral joint to be centered, just like our other shoulder x-rays. But the main thing is we do want this nice, clear, open space right here on this x-ray. Now, let me go back a second because I want you to be able to see the difference. I should have put these 2 pictures side by side. Going back, look at our internal rotation shoulder. See how the humerus is very much superimposing the scapulohumeral joint? We can't see it opened at all. We'll move forward to, here's our Grashy method. Can you see the difference there? The humeral head is completely separated from that glenoid cavity area. We have a nice, clear, open space to be able to visualize that joint space in profile. And that's the reason we oblique that patient 45 degrees. It's going to open that up just right to get a better visualization of the inside of that glenoid fossa or cavity. Scapulohumeral joints will be opened up. And a lot of times that's why we do our obliques. Obliques are very good at actually opening up joint spaces. Much like with the hand, we talked about earlier in the other chapter, it opens up all those joint spaces. Okay, so this is going to be our last special view of the shoulder right here. This is going to be what we call the Lawrence method, or the Inferosuperior axial shoulder. Inferosuperior axial shoulder. Now this x-ray, in comparison to the Grashy we just did, this one is always done lying down. We will never do this x-ray standing up. They must be lying recumbent and supine for this x-ray. Now the arm will be placed in a supination and abducted 90 degrees, much like we would for a lateral elbow. We're going to be at 40-inch SID, but we do add an angle to our tube on this x-ray. We're going to angle our tube 25 to 30 degrees medially to the axilla. Now you notice it's not a caudal or cephalic angle. If you look at the picture right here, well, it's talking about angling medially. Trying to get my drawing tool out here. Here's our central ray right here. We're angling 30 degrees towards the armpit. That's the axilla. That's what it refers to when we say we're angling 25 to 30 degrees medial to the axilla. Armpit is the axilla. We're putting a 30-degree angle and angling it towards the patient's armpits. That's going to give us a nice view of the head of the humerus, the joint space. And one of the reasons we would do this x-ray in particular is to check for dislocation of the humerus from the scapulohumeral joints. It's going to help us check dislocation. In fact, you'll see a lot of texts do this view instead of the typical Y-shot view, because the Y-shot view that we'll talk about later is also done for dislocation. This tends to be a little bit easier as far as positioning goes to check for that dislocated humerus. We will suspend respiration on this x-ray, much like many of our other shoulder x-rays. And you do have a choice of either using an 8x10 or 10x12 cassette in the crosswise position, using a cassette holder. You'll also notice this is done tabletop. We won't do this in a wall bucky or table bucky. It's always done tabletop. And like everything else, we are using that gonadal shielding. Do make note that there is an angle on this particular x-ray. Not a lot of angles this chapter. This is one of the few that we're going to talk about. It's a 25 to 30 degree medial angle towards the axilla or patient's armpits. As far as that centering goes, that's also easy to center because we are putting that central ray, that crosshair, directly on the patient's axilla, which is a fancy way of saying armpit, by the way. You hear someone refer to the axilla, that's the armpit. And here is our evaluation criteria. Now, for this x-ray in particular, we do want to visualize, much like an internal rotation, the lesser tubercle profiled anteriorly. So we are looking for that lesser tubercle to be profiled, much like an internal rotation shoulder x-ray. We also want to see the humeral head and the glenoid fossa profiled. And why is that so important? Well, like I said before, we want those profiled because they do use this x-ray as a means of checking for dislocation of the humerus from that scapulohumeral joint. So this is actually in place. This is how the humerus should fit in the glenoid fossa. But if this humerus was out of joint, it'd be higher or lower than that joint space, and they'd have to pop that arm back into socket. Our lesser tubercle is right here on this x-ray, by the way. It's at the top. It's going to be our lesser tubercle on that Lawrence method Inferosuperior axial projection. I did include this image on your practice images, guys. Do make note that that is the lesser tubercle right there. Of course, glenoid fossa, scapulohumeral joint right there. You can still see the coracoid process, which is right there. And our acromion, which is outlined right there. Okay, so before we get to our trauma positions, guys, let's take a quick break. Go ahead and take 7 minutes. We will reconvene at 1:57, and we will continue on with our trauma positioning of the shoulder.
Saline.
Okay, everybody, let's get back into position here. We're going to keep moving along. All right, let me get the PowerPoint pulled back up. Okay, so the next few positions that we're going to go over here, guys, are primarily, we're talking about shoulder trauma views. So once again, this is if the patient presents with a very bad fracture of the humerus or shoulder area, and it's so bad that they can't position the arm in the traditional sense to get those normal views that we would traditionally try to acquire. So these are reserved specifically for our trauma patients only. So as far as the routines for trauma shoulders, it's going to be what we call the neutral rotation and the scapular Y X-ray. And for the special, we're going to do what's called the transthoracic lateral shoulder, which will be very similar to that transthoracic lateral we talked about on the humerus on Monday, or today rather, I'm sorry. So for the routine, once again, that's going to be our neutral rotation and our scapular Y. Let's talk about that neutral rotation first of all here. So neutral rotation is simply that. It's done exactly like we would do a normal shoulder x-ray. The only difference is we're not going to rotate the hand inward or externally. We're just going to let the hand simply hang by the side in a neutral position, or essentially as if the hand was in a lateral position. Now, obviously, this is not going to be an ideal x-ray. Oops, I get this to go away down here. This is not going to be an ideal x-ray because if you remember, from the anatomy we were going over, in a neutral rotation shoulder, we're not going to see either tuberosity in profile. In fact, they're both going to be superimposed upon the interior surface of the humeral head. But if that patient absolutely cannot turn their hand, this would be some way that we could at least acquire a shoulder x-ray and still hopefully see what's causing them so much pain that they can't turn their hand and be able to identify where, if there is a fracture present. Now, this can be done erect or lying down. Both would be in the AP position. That arm, like I just said, is going to be in the neutral position. And the epicondyles, they will be set at a 45-degree angle. So if you remember back to what we were talking about, external shoulder, epicondyles are parallel to IR. Internal shoulder, epicondyles are perpendicular to IR. And the neutral rotation, the epicondyles are at a 45-degree angle to the IR. So those epicondyles do change quite drastically between those three views. Now for centering, it's done exactly the same as a shoulder. We're still palpating for that coracoid process and putting that CR 1 inch below or inferior to that coracoid process. We are still suspending the respiration, 10 by 12 crossways cassette, wall or table bucky or tabletop. And of course, gonadal shielding. Literally the exact same as the shoulder x-rays. We're just once again changing how we have that hand oriented, depending on what we're trying to acquire here. Now, don't be one of those lazy techs, and just because the patient says I'm hurting a little bit, refuse to turn the hand, because even though patients are hurting, most of the time they can still cooperate with you and rotate that hand internally and externally. This would be just basically a last resort shoulder x-ray if the patient should completely refuse to rotate their hands, or if they're actually unconscious and passed out and you're in the trauma room, you get a shoulder x-ray really quick. We just go ahead and do this neutral rotation and get out of the way so they can at least see what's going on in that shoulder area. So that's going to be our AP neutral rotation, and that is reserved primarily for our trauma patients, patients that cannot move their arm. Okay, so what are we looking for as far as evaluation criteria? The greater tubercle will be superimposed, and I will add to that. I would add that to yours as well. The greater and lesser tubercle are both superimposed. It's not just the greater. They're both superimposed upon the anterior surface of the humeral head. Scapulohumeral joint, though, will still be centered because we are centering an inch below that coracoid. The only difference is we're just not moving that arm the same way. We want to go ahead and still include as much of that clavicle as possible, as much of the proximal humerus as possible, and of course have our joint in the center of that film to at least try to evaluate as much of that shoulder as possible, even though we can't properly position that arm in the traditional sense. All right, so now we have the transthoracic lateral proximal humerus. This is essentially, guys, done almost exactly the same way as the transthoracic lateral humerus x-ray. The only difference is we're doing only the proximal portion of the humerus, or the shoulder area. And this is if we need to get a lateral of that proximal humerus. And once again, it's fractured so bad they can't move it in the traditional sense. So as far as positioning, we are going to position very similar as we would for a lateral transthoracic humerus. The only difference is we're going to be a little bit higher because we are focused only on the proximal section of that humerus instead of the entire humerus. Now, as far as the positioning goes, the patient can be lying down. If they're lying down, that will be a cross-table x-ray. But preferred, we want them to be standing up in the erect position. We're going to put the affected arm in the neutral position, resting along the body. That will be the side that's closest to the IR. And we're going to have the unaffected arm up above the head, out of the way, so we can shoot straight through the torso and acquire a nice lateral view of that proximal portion of that humerus. We do want the humeral head to be centered to the central portion of the IR. That's the easiest way to position for that, by the way, is if you figure out where the humeral head is, put that right in the central portion of your wall bucky. That's going to be the correct centering point for that x-ray. For our CR, the exact location is we're going to have a perpendicular or horizontal CR entering what we call the lateral thorax of the unaffected side, that essentially will be perpendicular to the surgical neck of that humerus. And if we have that humeral head resting on our IR directly in the center of it, if we line up our CR to the wall bucky, it should enter right through that surgical neck of the humerus. So once again, we are only wanting that proximal portion of the humerus instead of the entire humerus, like the previous position we talked about on the humerus positions. So same as that other x-ray we talked about, we are going to have the quiet, shallow breathing. The main reason for that is the same exact reason. We want to actually blur out the ribs, help them get a little fuzzy so we can better visualize that proximal portion of the humerus through the thorax, because we are going through a very thick portion of the body. We're going to put our we're going to use a 10 by 12 cassette. And it's going to be a lengthwise cassette, because we are doing that proximal portion of the humerus. We don't need it to be wide, we need it to be long. And we'll use that wall bucky or tabletop with a grid. And we do need a grid because we are penetrating through a very thick portion of the body. We want to clean up that scatter and help raise the detail on that humerus in that lateral view that we're trying to acquire. So this will be our transthoracic lateral proximal humerus. Primary focus is that proximal or upper portion of the humerus close to the shoulder joints. So our evaluation criteria, we do, of course, want to see the proximal humerus clearly seen. We also want to be able to visualize very clearly the humeral head and the glenoid cavity. The glenoid cavity will be a little harder to see on that x-ray, but we want to be able to try to visualize it as best as possible. We are going to have the humeral head in what we call neutral rotation. Why is that? Because we are simply resting the arm in the neutral position, much like the neutral shoulder x-ray. And then, once again, we're not focused on the entire humerus. This is only that upper portion or that proximal portion of the humerus where a lot of those fractures do occur. Because if you do remember, that most fractured portion of the humerus is going to be the surgical neck area, which would be right here, close to the humeral head, surgical neck. Okay, so for a scapular Y, this is going to be our third trauma view for shoulders. This is going to put the actual scapula into a lateral view. That Y shot we talked about earlier on the anatomy, that's what this is going to be. And this is going to be done primarily when we have a suspicion of a dislocation of the shoulder. So you remember we talked about that Lawrence method. That Lawrence method before, where we're shooting to the axillary area, the armpits, that's the alternative that's done to this x-ray right here. Because most techs will opt to go ahead and do the scapular Y. And why do we do the scapular Y? Primarily to check for dislocation of the humerus from the scapulohumeral joints. That is the main reason we do this x-ray. So this is done erect only. We only do this with the patient standing up. We do put the patient in an anterior oblique. And we're going to rotate that patient at an approximated obliquity of 45 to 60 degrees. Now you'll notice that's a bit of a wide range there. Now the reason we give that wide range is that every patient's scapula is built differently. They're shaped differently. And depending on your patient, you might need to make small adjustments to how your patient is obliqued to get that scapula into a true lateral. So for example, looking at you guys right now, one of you might be a 45-degree angle. One of you might be a 50-degree angle. One of you might be a 60-degree angle on that obliquity to get that scapula in a true lateral. We can't really see that until we shoot the x-ray. So we go ahead and put that range of 45 to 60, and we do our best to try to palpate that scapula as you learn in the lab to get that into a nice true lateral, hopefully the first time. But if we don't, we'll make those small adjustments to how we oblique the patient in the hopes of putting that scapular body into that true lateral and get that nice, beautiful Y shot. So alongside putting them in that degree of obliquity, we're going to abduct the arm slightly, like you see the patient doing right here. We're going to center the scapulohumeral joint to the IR, and we're going to palpate those scapular borders because, like I just said, we want to try to make sure we have that scapula as close to a lateral as possible. So we're going to press on the patient's back, feel for that medial border of the scapula, and try to position them using our x-ray vision that we develop over time, put that in a true lateral with the hopes of getting it the first time. A lot of techs hate this x-ray. I hate this x-ray a lot as well because you do a little bit of what I hate to say is guesstimation to get that true lateral, because depending on your patient's shape, we just don't know how it's going to look till we actually shoot the x-ray. Thus, we have that range of obliquity, which is 45 to 60 degrees. Now, as far as the CR is going to be a perpendicular beam, we want that beam to actually exit the scapulohumeral joints. We are going to suspend the respiration completely. And we're going to have our 10 by 12 cassette lengthwise. Very important to remember because a lot of our shoulder x-rays, we do it crosswise, but for the lateral, we actually put that cassette lengthwise because we want to include the entire scapula. And as you know, the scapula is long, not wide. We want to make sure we have the top portion all the way to that inferior border of that scapula included on that x-ray. This will only be done on the wall bucky. Like I said, we're not going to lie them down. They must be doing this standing up or erect. And we're going to put that gonadal shielding on their back and their posterior surface because we are opting for that anterior oblique. Now you will see some techs do posterior obliques for this x-ray, but the preferred method, at least by what Von Traeger states, is going to be the anterior oblique, which you see the patient demonstrating right here, where they're actually facing the IR in that 45 to 60 degree oblique position. So like I said, just make note, it can be done as a posterior oblique, but it is preferred as an anterior oblique because you can palpate that scapula a lot easier in this position. So that's our scapular Y lateral. Once again, done primarily to check for dislocation. And that's what our x-ray should look like right there. It's showing you a normal scapular Y versus one that has been dislocated. So as far as what we want on the x-ray, we want the body of the scapula to be superimposed on in, which we see right here. Can't get my drawing tool out here. We want that body to be completely superimposed. If it looks oblique, we know the patient's not in a true lateral, and that's where we got to make those small adjustments to go ahead and rotate them a little more to accommodate and put that scapula in a nice true lateral. We do want to see the acromion and coracoid processes in profile, which we see right here. There's our coracoid. Over here is our acromion. We want to see both of those in profile. And we do want the humeral head and the glenoid cavity to be completely superimposed upon one another. Also, you will notice that the scapula will be on top of the shaft of the humerus. That's normal as well. If that humerus is not dislocated, we will see the body of that scapula superimposed quite nicely upon that humerus. Now, obviously, if it is dislocated, as you see over here on the right, that scapula is going to be free superimposition because the humerus is completely out of socket over here. So like I said before, on the left, that's a normal humerus in the correct joint space versus one that is completely dislocated out of socket. That's the main reason we do that scapular Y lateral x-ray. And once again, just usually it's a text. Most of the time, this is a text least favorite shoulder x-ray to do. It's always mine as well, just because you have a lot of estimation that goes into it as far as how much you need to oblique that patient. And just make sure you know that entire range. I know I often tell you guys to pick one number for obliquing, but for scapular Y, make sure you do know that whole range of 45 to 60 because it does vary depending on your patient's actual anatomy to get that scapula in a nice true lateral. All right, so we're going to move on now to our clavicle and AC joints. We do include those in our shoulder girdle area. So our routine projections, these are all going to be routine projections, by the way, is going to be our AP and AP axial clavicle and our AP AC joints with and without weights. With and without weights. I'm sure that's a little obscured by my computer screen there. But those routine projections are AP and AP axial clavicle and our AP AC joints with and without weights. So let's start with our normal AP clavicle. So this x-ray can be done lying down or erect, but much like most of our shoulder girdle, it is preferred to do this in the erect position. It will be an AP position at 40-inch SID. As far as where your CR needs to be centered at, that's going to be on the mid-clavicle. So you will need to palpate your patient's collarbone, palpate their clavicles. We can find the joints, go in the middle of those two joints. That is the mid-clavicle, halfway between the AC joints and the SC joints, mid-clavicle. And we do take this x-ray on inspiration. We do take this on inspiration. Do make note of that. We're not going to suspend respiration. We actually take this x-ray on inspiration. It's going to be on a 10 by 12 cassette, and we're going to use what's called slit collimation. What slit collimation refers to is just very narrow collimation, which we see right here. So it goes without saying the clavicle is a very thin bone. We don't want to leave that collimation wide open because if we leave it wide open, as you saw in some of those previous shoulder x-rays, the clavicle will get more burned out if we have a wide collimation. Therefore, we tighten up our collimation to a very narrow beam, narrow light field. It's going to help that clavicle pop out on the x-ray, give us that nice detailed trabeculae showing those fractures if they're present on that actual clavicle. And that can be done on a wall bucky or table bucky. We do want to use a bucky for this x-ray because the shoulder is thick once again. And of course, we're going to use our gonadal shielding on the anterior surface of the body because we are going to do this only in the AP position. We do not do PA clavicles. They only come in AP, 100%. Now, what do we do on the other view for a clavicle? We're still going to keep our patient in the AP position, but our second view of the clavicle is not a lateral, but an AP axial clavicle. Therefore, we are going to angle our CR a little bit in a cephalic direction. And the reason we do this second view is we're going to angle the CR to throw the clavicle above the shoulder to better visualize it. Because the clavicle naturally sits very close to the joint space, the ribs, and the scapula. It's a little bit superimposed. When we add that cephalic angle, it throws our clavicle up and isolates it so we get a little bit better view if there is a fracture present. And we will always do a normal AP followed by that AP axial view. We never do just one or the other. We do both every single time. That's the routine of clavicles. Now, much like the AP, this can be done erect or lying down. We're still at a 40-inch SID. The only difference is we are adding that angle and that's a 15 to 30 degree cephalic angle. The most common angle chosen for this x-ray is the 15 degree cephalic angle, but you do have a range there should you choose to use it. But more often than not, the 15 degree cephalic angle is sufficient to throw that clavicle above the shoulder. CR is still going to be the exact same spot. It's going to be the mid clavicle, and just like the other x-ray, we are taking this image on inspiration, still using our 10 by 12 cassette with slit narrow collimation. We are having them stand up at that wall bucky, or if they're laying down, we're going to use our table bucky to accomplish the area and clean up the scatter to better visualize that clavicle. Should still be some nice shielding there on the AP surface, protecting patients. Very easy competency to acquire once you guys test out on this next week. Clavicles come in quite a bit. They are quite easy to do. That's a great one to jump on this semester if you get a chance. Very simple x-rays to do. Very hard to mess up. And do make sure, as always, guys, when you're doing this narrow collimation, leave yourself just enough light on your IR so you can put your marker on there, because that's an easy, probably the biggest mistake on this x-ray is clipping markers, because you use that very narrow collimation. So always leave yourself just enough light to fit your marker in there. That way you can count your competency. So what would the x-rays look like? Well, there we have them on top of each other. We have the normal AP at the top here, and the AP axial right underneath. And that's the easiest way to identify the two, is to actually look for a marker saying AP and AP axial. If that was not present, we look for a very distinct space between that first rib and that clavicle. That tells me that there's an angle on that tube, and I'm throwing that clavicle up above, I'm sorry, not the first rib, above the superior portion of the scapula, superior border of the scapula. We're throwing it up above to bring it out of superimposition and get a better visualization of that clavicle overall. So our normal AP, it's very close to the superior border. On the AP axial, there's a very clear space designated between that clavicle and that superior border of the scapula. And we do want the entire clavicle demonstrated. That's a little different from the shoulder x-rays, where we just want to have most of the clavicle. Because we are focusing on that clavicle, we want the entire clavicle demonstrated. That's from the SC joint all the way to the AC joint, or sternal end, all the way to the acromial end. And we want that nice four-sided collimation, because if I leave my light field wide open, like I said before, it's going to actually burn that clavicle out. We're not going to be able to visualize it very well at all. And then AP axial, like I just said, we want more of that clavicle seen above the ribs, primarily above that superior border of the scapula, in that nice distinct space, that we can make a nice differentiation of that clavicle and better visualize if there's any fractures going on, get them along their way, get them fixed up. Very common fracture, the clavicles, and quite often. All right, guys, I'm actually going to stop right there, because I don't have enough time to go fully into AC joints, because there's a little more to explain on AC joints. So we'll go ahead and stop there today. So we are actually almost done with the chapter. We don't have much further to go. We have about 10 slides left. So Friday, we will wrap up this chapter, and I will put together a review for you guys that we can all do in class to make sure you're prepared for your tests. We'll review some anatomy, review the types of questions you can expect, and get yourself all prepared for your 2 exams that you have next week. Do make sure you make note that the image review exam will be on Monday. The lecture exam will be on Wednesday of next week. So start studying. It's a lot of information coming at you. Are there any questions about what we discussed today, guys? But before you leave, I do need to announce the winner of the model. And I got it narrowed from 4 to 2. I had a very hard time deciding on this, but it all came down because the anatomy labeling was excellent on everybody. That's what you guys knocked it out the most on. So I really narrowed it down to detail and accuracy of the actual bony landmarks. And for that reason, the winner this time around is going to go to Naomi. So good job, Naomi. You are the winner this time around. You have won the bonus points, and we will.
Thanks.
You're very welcome. We will continue our competition in the next 2 chapters coming up. It's going to get more and more difficult, so prepare yourselves. I won't tell you what you'll be making, but we'll be making a lot more stuff as we move on. Very well done. You guys made it really hard this time, I will say. It was hard to make a decision. I was quite impressed. Let's see. So yes, I will share that as well. We'll do a big, massive review on Friday, guys, to prepare yourself. If you have any specific questions, please let me know. And I will see if I can gather some more practice images as well to share for you guys before the exam. One thing you can do on those images I sent you to, by the way, guys, if you go into Microsoft Word, create actual boxes to cover up the anatomy, put those boxes on the anatomy, and the best way to study for that anatomy is to see how much you know. You can delete the box, and it will really check your answers. That's what I've done in the past to study for anatomy. It works very well. I definitely recommend doing that. All right, guys, if there are no more questions, you are dismissed. Have a wonderful afternoon, a good day at clinic, and I will see you guys on Friday.